Meaningful Use 3. I would like to briefly review the agenda for this webinar. First, I will explain how to submit a question to our presenters. Then, Rebecca Roper, Director of the Practice-Based Research Network Initiative at the Agency for Healthcare Research and Quality, AHRQ, will introduce today's presenters. We will hold a Q&A session after each individual presentation, then a longer Q&A session at the end with all presenters and discussants. At the end of the webinar, I will explain how to obtain CME credit for participation in this webinar. Please note that after today's webinar, a copy of the presentation slides will be emailed to all webinar participants. If at any point during this webinar you have trouble hearing our presenters, please try hanging up the phone or headset and dialing back into the webinar. Please note our presenters' disclosures here below. I will now explain how to submit a question to today's presenters. To submit a question, you may use the GoToWebinar control panel. Type a question under the Questions section and hit Send, as shown in the screenshot on this slide. You may submit a question at any time throughout the presentation. During the Q&A sessions, as time allows, your questions will be read out loud and our presenters will respond. I will now turn the presentation over to Ms. Roper.
Good afternoon. So thank you all for joining us, both the presenters and the attendees. This wonderful group of presenters, their research was spawned in response to an AHRQ call through a special emphasis notice that was framed by Dr. Jonathan White, who had been working with ONC and CMS to see how innovative folks could test out some of the objectives with respect to meaningful use. I just want to point out to you, we just released as of yesterday a similar mechanism, a special emphasis notice that was released by the Health IT division to encourage research projects either of the R21 nature or the R01 nature on health IT safety. The notice number is NOT-HS-15-005. Take a look for it. We would welcome your submissions. They hope that this will be fiscal year 2015 funding. Many of you are working in this area. Perhaps you've had an idea percolating around. Now's the time to polish it up and send it in to us if it is of interest to you. So keep those good ideas coming. Today we will hear 3 of the awardees for the special emphasis notice for meaningful use. We will hear from, well, 3 projects I should say, from Dr. Alex Fiks in Philadelphia. He is a faculty member at Children's Hospital of Philadelphia, commonly referred to as CHOP, and he is an exceptional leader in the pediatric research office settings PBRN called PROS. And really, if you look throughout the AHRQ catalog of activities with Health IT, has done a great deal of work in advancing our understanding of clinical decision support, personal health care records, as they can be helpful for both children and their family, as well as the clinicians who provide them care. Our second presenter is Dr. Muriel Jean-Jacques from Chicago. She specializes in general medicine and geriatrics, and her research generally focuses on the evaluation of intervention to eliminate disparities in preventive and chronic disease care through the use of Health IT and the care team redesign in primary care settings. And our third team of presenters is a dual presenters, Dr. Sarah Scholle from the National Committee for Quality Assurance, and her colleague, Dr. Kimminau, who is a director of a PBRN center at the University of Kansas Medical Center, and with a great deal of expertise in cultivating community relationships and health improvement through a really diverse means of activities. So they'll be presenting in full they'll be our third presenter. What we're going to do today is have each presenter give about a 15-minute overview of their project, and then we'll have question and answers for that given presenter, and at the end we'll have an open discussion. Now, we are really lucky because there were a few other awardees to that robust SEN. Dr. Steve Ornstein, who's presented presented 3 times on his Meaningful Use project, and Dr. Valerie Pavlik, who will be presenting on not presenting, but will be commenting, maybe posing questions. Previously, she too has given presentations both at NAPCRAG and through Health IT about their after-visit summary. And Dr. Ornstein has given presentations on their project along with other team members at NAPCRAG, and we can give you those citations and follow up to this meeting. So with that, we will turn it over to Dr. Fiks, who will guide us in a discussion about spurring adoption of patient portals to collect patient-reported outcomes, lessons learned. Dr. Fiks?
Thanks so much for that introduction. Just checking with the folks at AHRQ, making sure you can hear me and see the screen.
Yes, we can.
Excellent. Thank you. So, as Rebecca said, and thank you very much for that introduction, my presentation today will be on spurring the adoption of patient portals to collect patient-reported outcomes, lessons learned. This project was supported by the Agency for Healthcare Research and Quality with additional support from the Children's Hospital of Philadelphia and the Eunice Kennedy Shriver National Institute of Child Health and Human Development. By way of background, the Meaningful Use Program was created by the Health Information Technology and Clinical Health Act, which was part of the American Recovery and Reinvestment Act of 2009, also known as the stimulus. And it's a program to promote the spread of electronic health records to improve health care. The program has 3 stages. Stage 1 focused on data capture and sharing, Stage 2 on advanced clinical processes, and Stage 3, where this work is focused on improved outcomes. In particular, one of the areas that Stage 3 focuses on is developing strategies to better engage patients and families, and patient portals are one of the means to achieve that goal. The other aspect that's unique about our project is that we're focused on pediatrics. Work in pediatrics in the context of meaningful use matters because early in the program, fewer than half of pediatricians were participating, and the qualifications for pediatricians to participate in the program are different than those in adult health care, in part because of differences between the Medicaid and Medicare criteria. Patient portals are secure online websites that give patients convenient 24-hour access to personal health information from anywhere with an internet connection. In the context of this project, they're important because they are one of the primary means of enabling people to provide patient-reported outcome data to their healthcare providers. With that background in mind, our project had several broad questions. First, what innovation, characteristics of the technology itself, organization, characteristics of a particular health system, and structural characteristics of perhaps the incentive program itself, which of those characteristics would be most influential in portal implementation? And likewise, how might meaningful use incentives and supports be structured to promote the adoption, sustained use, and clinical benefit of these systems? For our project, we used a conceptual model that we borrowed from the implementation science literature. The model looked at determinants of implementation success, particularly focused on structural, organizational, patient and family provider, and innovation characteristics. We looked at implementation outcomes, and ultimately we'll consider healthcare outcomes. Our specific aims focused on asthma and an asthma portal. We wanted to evaluate the feasibility and effectiveness of a patient portal to help manage care for children with asthma and to determine the barriers and factors associated with portal adoption and sustained use. The portal we studied was called My Asthma and was developed by a team at our institution. It has several features that were unique and helpful to families. It provides educational material to them, allows parents to identify concerns they might have about their asthma care, allows the parent and child to identify goals for asthma treatment, and these features were informed by a shared decision-making model. It tracks symptom, side effects, patient-reported medication adherence, and progress toward these goals over time, and then provides decision support so that if a parent checks in and poor control is found, both the practice and the parent would receive messages So this approach goes beyond traditional decision support models of only supporting healthcare practitioners to make it a shared model of decision support. Here's an example of a decision support message that a family would receive if they completed the portal and reported that the child's asthma was uncontrolled and that the child was experiencing side effects. First, they would be communicated that they had reported that lack of control. Many parents didn't recognize it. And then they would be informed that they should call their child's doctor's office. Likewise, at the same time, messages would be sent to the doctor's office informing them that the survey was completed, that asthma control was not good, that there were side effects experienced, and that a conversation was needed. Using this two-part approach was a way to close the loop and not just rely on the parent alone or the doctor's office alone to spark communication. The next slide highlights how the portal appears in both to the family in the portal and to the clinical team in the electronic health record. Looking across the top of the screen, you can see different domains. Highlighted in blue is the My Asthma Home. This is the home page. They can click on the box next to it for education, the box further to the right to access the asthma care plan, and finally on the far right to access the care team. The parent's goal, in this case not to miss work due to the child's asthma, is flagged. The child's goal of not missing school is flagged as well. Concerns are highlighted on the far right. Longer red bars highlight areas of greater concern, whereas shorter bars highlight areas that were also of concern, but less so. So for this child and his or her parent, steroids impacting growth was the major concern. The next part, and the focus of the data presentation in the portal, is a timeline that allows the user, either the family or the clinical team, to view both asthma severity and the trajectory of that severity over time. Green boxes indicate areas with no concern, yellow boxes areas of some concern, and red boxes areas of major concern. So as you can see in this particular case, the child wasn't doing especially well in December and January, but had been doing much better in September at the beginning of the timeline and at August at the end. And the notion of using these colors was to really make it clear to the clinician and to the family with a quick assessment and a quick view how things were going for the child. Before beginning this project, we had conducted a pilot trial of the system with 60 families. We found that 57% used it in 5 of the 6 study months, that most were satisfied, and that outcomes were improved. Families in the intervention group reported fewer flares, and parents in the intervention group reported fewer missed days of work. These results in aggregate warranted a larger implementation study to understand how portals might be used and how this portal in particular and ones like it might be incentivized through the Meaningful Use Stage 3 program. The setting of the study involved 2 practice-based research networks. The first is the Pediatric Research Consortium of the Children's Hospital of Philadelphia. In green is New Jersey, and blue is Pennsylvania. Within those 2 states, the network includes 1 main hospital, 3 urban primary care centers, 28 suburban and rural practices, 13 specialty care centers, and 6 pediatric inpatient units at community hospitals. The project also took place within PROS, which stands for Pediatric Research in Office Settings, the practice-based research network of the American Academy of Pediatrics. That network has over 700 practices across the United States and into Canada and Puerto Rico. So in terms of study procedures, we recruited 20 practices, 9 from PROS and 11 from the PERC networks. About 2,000 families of children with asthma within PROS practices were identified, and these children were identified based on their electronic health records having a mention of asthma within the prior year. And 7,000 families of children with asthma were identified within PERC. They were recruited for the portal with 2 rounds of mailings, so given the number of children, over 18,000 letters were sent. The study team then called 50 families at each practice to see if that at all improved response to the portal and sign up. Providers and offices were also giving cards allowing families to have the information they needed to contact the team and sign up for the portal. Despite all of these measures, however, enrollment was low. We found that 130 children enrolled at PROS practices and 164 enrolled at PERC practices. Importantly, nearly a quarter of those responding had active asthma symptoms that required attention. This slide shows the range of my asthma adoption across practices. Each line represents an individual practice. Practices in green are part of the PROS network and are from across the country, including Alaska, Kansas, California, Oklahoma, Ohio, South Carolina, Tennessee, Missouri, and Kentucky. And practices on the right are from the PERC network and our Philadelphia area practices. One of the lessons that's readily discernible here is that the adoption of the system was widely variable across practices. In addition, all PROS practices on average had 6.5% of eligible children enroll, whereas in PERC that number was much lower at 2.3%. This finding was associated with the fact that within PROS, signing up for the portal within PERC, signing up for the portal involved a more cumbersome process where the family needed to be in touch with someone within the health system and be walked through a multi-step process. For PROS, the version of the portal allowed people to enroll themselves, which decreased barriers. After completing the portal, we found that 30% of families indicated that they would take at least one new action to better manage their child's asthma. These results overall indicate that the portal really is a tool to change asthma management and to impact clinical care. Specifically, 19% of families were much more likely to change their environment at home. 16% of families were much more likely to speak to their doctor. And about 1 in 8 or 12.5% of families were much more likely to make a change to their child's medications. In addition to this quantitative data, we also conducted focus groups with providers and individual semi-structured interviews with parents to better understand what was driving portal adoption. Several themes emerged. From the provider focus groups, we found that many families with asthma in the child's chart did not believe their child presently had asthma. So 20 out of 50 children in one practice who were contacted by those follow-up phone calls had families who didn't believe their child's asthma was an active issue, despite it having been flagged recently within the electronic health record. We also found from clinicians that they felt that clinician referral for the portal might be better than letters or phone calls alone. Despite this widely held view, we found that most clinicians, even when given the cards, large number of cards, to refer families to the study team to enroll, that the cards weren't widely distributed and that most of the families that enrolled weren't enrolled through that strategy. An additional realization from the provider focus groups or theme was that streamlining the sign-up process may increase enrollment. And we also saw that in the quantitative data with PROS practices with simpler enrollment having higher numbers of participants. The next theme, I think, is an important one, and that was that ongoing training and administrative assistance may be needed to further solidify portals as part of the clinic's asthma workflow. This is an aspect of technology integration that we'll hear about more later on in this webinar. But as one clinician said, we haven't built a great infrastructure in terms of care coordinators. So until we feel secure that it's in place and really well running, it feels like we're putting the cart before the horse. So this reflects the whole notion that in order to effectively collect patient-reported outcomes, office systems have to be very well set up and defined in order to understand what to do with that information and how to use it to improve care management. Providers also mentioned that the portal was very helpful in identifying children with active asthma symptoms. One of them said, I had this kid who was really doing really bad. We didn't know that until the questionnaire went to them, which prompted an allergy evaluation. She's gotten much more on board with things. She has filled the asthma portal out and has shown improvement. So a sign of progress there. We also interviewed parents. The following themes emerged from those parent interviews, and these on this slide particularly focus on parents who enrolled. They felt that the portal helped identify their own children as having poor asthma control. As one said at the beginning, I would never have thought that his asthma was uncontrolled. She recognized it was uncontrolled and then said, now I have it controlled. Parents responded very positively to the instant feedback of such systems. As one said, I'm a single parent with 3 children, so I thought that the asthma portal would definitely be a time saver to be able to access the portal via the internet instead of having to call and wait for somebody to call me. So this ease of communication is an important theme and this connectedness to the office. Parents also cited the timeline as one reason for signing into the survey this month, as one said it allowed me to look really in depth about how often she was having a flare. And it also helped start conversations about asthma questions. One said it propelled me to call my doctor more and to ask more appropriate questions. We also spoke to parents who didn't enroll. Many of them responded that they were unaware of the portal or felt that letters were not an ideal method of communication for those that received the letters. So the letters themselves just didn't have the salience that perhaps a recommendation from the clinician might have had or from someone else in the office. And again, reflecting themes we had heard earlier, they did not feel that the child's asthma was a concern or felt that asthma was already well managed. And one said, my son's asthma is not very severe, so I think that if it was a significant daily type of problem for our family, then I probably would have been interested. But since it wasn't, they weren't interested. And so this is a very important issue in thinking about thresholds for participation and how incentives might be pegged to those thresholds, since many families or children who at the surface are perceived to have asthma may not really be having active symptoms. Several conclusions can be drawn from this work. First, that providing meaningful use incentives, or MU incentives for the portal, is warranted because outcomes may be improved. We saw that in real action that people wanted to take in response to the portals and in the comments they gave about their ability to better manage their child's care. From our work, participation thresholds should be low to start. There was some talk in some of the early guidance that was distributed about meaningful use stage 3 criteria that those thresholds would be set around 10% to receive incentives. Our results suggest that they should be set even lower. We also found that there's synergy needed between technology and office-based programs such as asthma care coordination. Practices clearly need more than technology to effectively use it to achieve the kind of outcomes that meaningful use stage 3 is trying to promote. And finally, tools such as this should be focused on children with active health problems. More work is needed to facilitate the identification of these children within EHRs. As the example illustrated earlier in the talk, we had a lot of children who did not have active asthma who would have been counted in denominators for meaningful use, yet weren't really the target population. And so there needs to be a better way of flagging and identify children who are really in need of active disease management, who may be the primary audience or a primary audience for submitting patient-reported outcomes to the health system. Finally, I'd like to thank our My Asthma Study team, including a wide range of researchers and staff who contributed, and informatics experts who contributed to the success of the project. Thank you very much, and I'd like to pass the webinar back to AHRQ and our next speaker.
So while you've been presenting, there have been several questions with respect to context of the Health IT functionality that you required in this particular study with respect to where is the EHR located, is there connectivity with the hospital, can patients gain access to the portal either through an app or remotely through a phone. So could you elaborate a little bit with respect to those issues?
Thank you, Rebecca. Yes. One of the specifics of the call for proposals related to the Meaningful Use Project was to develop systems that could work in different settings. So in the PROS network compared to the PERC network, we actually had two approaches. In PERC, the asthma portal was actually implemented within MyChart, our vendor-supported patient portal system, and was linked then with the hospital EHR directly. And so all messaging from the portal flowed seamlessly from within the electronic health record and went to the practice. Within PROS, a separate system was used where the portal was developed using a web-based system that families could sign up for, and then information would be transferred to the practice. But the system in PROS was not tightly linked to the electronic health record. It was just a way to submit information to the practice that the practice could then act on.
Great, thank you. So yes, when the Special Emphasis Notice was created, it was created to provide an opportunity to test some of the anticipated functionality for Meaningful Use 3. And as noted by one of our folks out there, Meaningful Use 3 has not yet been enacted, and it was delayed. So these types of research activities have been able to inform the greater dialogue that is ongoing with respect to meaningful use as it progresses, and by the practitioners, the vendors, etc. So with that, thank you very much, Alex. And we, if you could hang on at the end, we may have more questions that we'd like to share with you. And our second presenter will be Dr. Muriel Jean-Jacques.
All right, so I really appreciate this opportunity to share our work with you all today. And please definitely let me know if there's any problem with the sound or if you're not able to see my screen well. So our study focused on best practices for integrating clinical decision support into clinical workflows. And this project was undertaken in partnership with the Alliance of Chicago. The Alliance is a network of community health centers serving primarily low-income and uninsured patients. Its founding members were 4 community health centers in Chicago that came together to share resources and integrate services in order to more efficiently and better provide care to their communities. And in particular, they worked on sharing resources regarding electronic health record systems. The Alliance has since expanded to what's called an electronic health record system user community that includes 34 federally qualified health centers across the country. They're located in 14 states, and across those 34 health centers, there are over 180 clinical sites. The Alliance also serves as a practice-based research network and has been a member of the Community Health Applied Research Network, which was funded through HRSA. So when the Medicare and Medicaid EHR incentive program, lovingly referred to as Meaningful Use, was launched in 2009, expectations were very high regarding the potential for electronic health records to help transform the quality and value of healthcare in the U.S. And to meet those expectations, the investment in health information technology and electronic health records in particular by both public and private sectors has been very, very impressive. But now we're getting to the point where people are really starting to get impatient to see the return on investment and to see the fulfillment of what is really the holy grail of meaningful use, which is getting to the stage 3 level of achieving improvements in health outcomes. So one component of electronic health records that our team has focused on is clinical decision support. So clinical decision support has been promoted as a tool to facilitate adherence to evidence-based practices, clinical guidelines, and to improve the overall quality of care. And the traditional or conventional definition of clinical decision support has really focused on the technology itself, describing it as a system that can aid in clinical decision-making, in which characteristics about patients that are present in the record can be used to generate patient-specific reminders, alerts, facilitate order sets. So it's really been thought in terms of the technology, the alerts, the reminders, the order sets. But as Dr. Fiks mentioned, practices do need more than technology. And so a more contemporary definition of clinical decision support focuses on the process as well and defines it as a process for enhancing health-related decisions and actions with organized clinical knowledge that's pertinent to the patient and can help to improve healthcare delivery. So it really focuses on the fact that the people and the processes are as important as the electronic system. So far, the evidence on clinical decision support and clinical outcomes has not been too strong. There have been a few systematic reviews published so far that have shown that clinical decision support has a modest effect on clinical processes, and so far a pretty minimal effect on clinical outcomes. And leaders in healthcare quality have given some possible explanations for this, often focusing on the fact that you can't just turn on a clinical decision support system and expect it to work. You can't just move a paper chart into electronic format and think that by it being more legible or looking prettier, that that's going to lead to improved outcomes. And really focusing on the fact that the clinical decision support has to be linked with processes, workflows,
as well as it must include not just what was in a paper record, but the built-in capabilities to support population health management. So some solutions that have been offered for how to get from just the technology of clinical decision support to the whole process of improving care delivery. Some solutions have included using clinical decision support implementation toolkits, using practice coaches to work with providers. And while these solutions sound nice, some of the practical questions that we had were, which of these implementation strategies, for example, a toolkit or a practice coach, would be most appropriate for healthcare providers? How does the designation of most appropriate differ based on the characteristics of the clinical practice? And our particular concern was how well would these different implementation strategies work in safety net settings that serve populations that historically have had the worst health outcomes, low income, uninsured, and racial and ethnic minorities. So we set out to determine the level of support that eligible providers would need in order to achieve the Stage 3 CDS objective. And the Stage 3 clinical decision support objective broadly aimed to improve the use of CDS to improve performance on high priority health conditions and to get to sort of outcomes-oriented population health management. The specifics have changed over the years and has differed on the number of clinical decision support interventions that would have to be implemented and the target areas, but the overall goal has remained the same. So our specific study aims were to determine the intensity of support that federally qualified health centers would need to achieve the goal of the Stage 3 meaningful use CDS objective. And we examined what we called a low-level intensity support, which was just use of a toolkit on its own, or a higher-level support, which would include use of a toolkit with practice coaching. The health conditions that we focused on was one preventive condition, which is the general area of cardiovascular disease prevention, and as well as a chronic disease. And for us, we focused on asthma. And we wanted to determine how the intensity of support might vary based on the health center's care management infrastructure. And we used their patient-centered medical home level to measure that. And our hypotheses were that centers with lower care management infrastructure would need higher levels of support, for example, practice coaching, in order to achieve improvements in their clinical decision support use. So 3 of the 34 Alliance Health Centers participated in this project. Center A was in an urban location serving a predominantly Black and Latino population and had 8 sites. They had not yet started pursuing patient-centered medical home status. Center B was in a predominantly rural area and served a mainly white population, but also had a significant number of Native Americans and Hispanics, and had 10 sites. At the start of the study, they had already achieved the NCQA level 2 PCMH certification, which means that they're able to provide team-based care. And the 3rd community health center was in an urban area, served a heavily predominantly Black population, and had 14 sites. And they had achieved PCMH level 3 certification, which means that they were able to provide team-based care and population health management. So we undertook a site randomized trial. It was 6 months in duration, and the sites were stratified based on their PCMH status, either the low level 0 site, the level 2 medium site, or the high PCMH level 3 site. So for each strata, 2 sites were randomized to use of the toolkit alone, and 2 sites to use of the toolkit with a practice coach. The outcomes that we looked at included outcomes that assessed use of the clinical decision support itself. So for asthma, it was whether or not the asthma tool was used to assess asthma severity. For cardiovascular disease prevention, it was whether or not a formal cardiovascular disease risk calculator was used, that the Outside of the study, it was a Framingham risk score. Partway through the study, the guidelines changed towards using the ASCVD risk calculator. And then we also looked at a clinical process outcome, which was appropriate medication prescribing. So for asthma, it was that patients with persistent asthma were prescribed a controller medication. For cardiovascular disease, it was those who were eligible for primary prevention, who had a high estimated CVD risk. For the Framingham risk score, that was a risk of 10% or higher for having a heart attack in the next 10 years, and whether or not they had been prescribed or offered a statin medication. We would have loved to have included a real clinical non-process outcome, but the study was too short of duration to look at that. So each of the 12 sites that participated in this study was asked to put together a Cdf implementation team, and each team consisted of 3 members: 1 physician, nurse practitioner, or physician's assistant, 1 nurse, and 1 medical assistant. Prior to randomization, each CDS implementation team underwent a 2-hour training on use of the toolkit, and I'll talk a little bit about the toolkit in a couple slides. And for the duration of the study, each team member was funded for 2 hours a month to work on the CDS implementation. Each team got a monthly feedback report that included their site's performance on the target measures, and in addition, they received central health IT support from the Alliance if there were changes that they wanted to make to the clinical decision support as part of their activities. The 6 sites that were randomized to the lower intensity intervention were asked to work through the CDS implementation toolkit on their own and to submit monthly progress reports to the Alliance. In addition, for the 2 hours that they had a month, they were encouraged to spend 1 of those hours together as a team. The other hour could be spent, being a champion among their peer group, whether it was the nurses or the medical assistants or the physicians. The higher intensity group had the same amount of time carved out, but they worked with a practice coach. That was a practice coach that was part of the Alliance and had been trained along the AHRQ protocols on how to do practice coaching, practice facilitation. And so these teams spent an hour a month with the practice coach, and the other hour they could use at their discretion to work on this project. So all of the sites had clinical decision support tools available at the start of the study. So there were clinical decision support that targeted primary prevention of coronary heart disease. That tool included risk factor assessment. So for example, if smoking status hadn't been updated, the providers were encouraged to do so. It allowed providers to calculate or estimate patients' 10-year risk of cardiovascular disease using, throughout most of the study, the Framingham coronary heart disease risk score, but at the end, the new ASCVD risk tool. There were order sets to facilitate guideline concordant medication prescribing and to facilitate prescribing of generic medications for patients who had a Framingham risk score over 10%. And there were also included low health literacy appropriate patient education materials to talk about heart disease risk and statin medications. The baseline use of the coronary heart disease tools for the Alliance overall ranged from 0 to 18%, and for the sites participating in the study ranged from 3 to 16%, and that's the percentage of patients who were eligible for the tools. The asthma management tools were similarly structured. There was a trigger assessment tool, an opportunity for assessing severity of the asthma, validated questionnaires to assess asthma control, linked to order sets, and then asthma action plans and other patient education and patient self-management tools. And again, baseline use of these tools was low across the Alliance, ranging from 0 to 17%, and at the 3 health centers participating in the studies range from 2 to 17%. So the toolkit that was used, that the teams used in the study, is one that was developed as part of the ONC, the Office of the National Coordinator, for the Meaningful Use project under contract by, I believe, a consultant. And it was based on the CDS 5 rights framework. So the CDS 5 rights is based on the premise that clinical decision support should help to get the right information to the right person, including all members of the care team, not just the physician, but also other clinicians and patients and their families, in the right clinical decision support format, whether that be an alert, an order set, or patient portal, through the right channel, and then at the right time in workflow. The CDS 5 Rights Toolkit helps the users, the teams, to apply a structured support to understand their current information flows and their current workflows, to consider each step in care delivery, both things that are not visit-related and things that occur while the patient is in the office, as well as broader population health-oriented activities, and to help them in a structured way to identify opportunities for improving clinical decision support integration and improving communication. This is an example of a worksheet that was included in the toolkit. The teams would be asked to identify a clinical target, would get an update on their current performance on the target. We're asked to walk through all the stages that a patient may go through both in and out of the office, document their current workflows and information flows, and to document or brainstorm potential enhancements. So let me go through a little bit about the characteristics of the team members. So we did not require that team members have had prior experience in quality improvement or training in quality improvement. So nearly 50% of the team members had no experience, another almost 20% had just a little training in quality improvement methods. As far as prior experience working in quality improvement, most had had what they rated as a little to a moderate amount of experience working in quality improvement projects before this one. And as far as the tools that were available at the start of the study, the clinical decision support tools, for the asthma tools, the staff generally rated the tools favorably, most saying that they agreed or strongly agreed that it helped them to improve the health of their patients with asthma. But I would just remind you that the use of the tools, despite this pretty positive rating, was very low. Similarly, for the cardiovascular disease prevention tools, they were rated rather highly, but use of the tools was still quite low. So looking at the results from our study, so we compared the rates at over 3 months of a baseline period with 3 months of a post-intervention period for the study outcomes. So starting with whether or not the clinical decision support was used to assess cardiovascular disease risk. In the low intensity group, we actually saw a decline in use of CVD risk assessment. There was a slight increase in the higher intensity group, and the difference between the low and high intensity groups was statistically significant. I do want to remind you, though, that there was a major change in the guidelines for cardiovascular disease risk assessment that actually caused a lot of controversy in the medical community. So that may explain a little bit of why this pattern was seen or why there was a decline. We saw, again, declines in use of statins among those who were found to be at high risk in both groups, and no difference between the groups. As far as the asthma outcomes, whether or not this clinical decision support was used to assess and document asthma severity, it increased in both the low and high intensity groups, and there was no significant difference between the two groups. As far as use of controller medications for asthma, there was no significant change in either group or difference between the groups in that outcome. So this slide lists some of the types of workflow changes or things that the clinical decision support implementation teams at each site outlined or aimed to address. So the first thing is that they began to recognize that just changing provider behavior alone was not the only target of quality improvement or of this CDS integration project. And by this I mean that at the outset, looking at notes from the first couple of team meetings, they really said, okay, use of the tools is low, so let's go and tell the providers, more and more often and in a different way to just use the tools. And over the course of the study period and working through the worksheets in the toolkit, they started to realize that just telling people to do more and asking them to do things different was not good enough. You actually have to examine the workflow and why people are or are not using something, and see if things may be better fitted to other care providers. They identified opportunities to leverage the full care team, so from check-in staff through rooming nurses or medical assistants, volunteers that may participate in activities at the center, as well as patients. And they identified care opportunities outside of the traditional patient-clinician office visit. As far as enhancements or changes to the electronic health record that they identified, at the outset, most of the clinical decision support tools were really targeted towards the physician, nurse practitioner, or physician assistant at the time of an office visit. And one of the common themes was to make the clinical decision support available to nurses and at other times. For example, when doing results, having the Framingham risk score available at the time of the lipid result would be helpful. For doing phone follow-up with patients, having access to the asthma severity tools would be helpful. And for either one, having a vital sign indicating when things were out of control may be helpful to the medical assistants or other care team providers. And they also noted that the existing clinical decision support tools put a large burden of data entry on the highest level providers, which was thought not to be most appropriate or efficient. As far as the team evaluation of the CDS implementation toolkit, they definitely identified areas where the toolkit could be improved. They found it to be, in general, difficult to use, so pretty low agreement with the statements such as the toolkit is easy to use, or they felt confident using it, or that they thought others could learn to use it quickly, but high agreement with more negative statements such as the toolkit is too complex or too cumbersome. And there have been some revisions made to the toolkit since then to try to simplify it. So our conclusions were that the use of the clinical decision support implementation toolkit did lead to modest improvements in the use of clinical decision support targeting cardiovascular disease and asthma management. We did not find that practice coaching led to any higher rates of improvements compared to just using the toolkit alone. And we did not find that use of the toolkit, either with or without a practice coach, led to improvements in the desired clinical process outcomes at 6 months follow-up. So as far as potential reasons why there may have not been an effect, part of it may be related to the clinical decision support tools themselves, and that they were very data entry heavy. It may relate to the implementation toolkit, which was reviewed as being rather complicated or cumbersome to use, or it may just be a matter of short study duration. And I think that may be a big part, because by the time the study ended, many of the teams were only at the early stages of implementing the steps that they had outlined to try to improve performance on those measures. And also, we did not find that results differed based on the health center's baseline patient-centered medical home infrastructure. We did find that those with a higher patient-centered medical home level were able to move towards implementation of changes more quickly, but still we didn't see any change in outcomes at those sites. So some things that we put together as possible implication for practice improvement was that the use of the what is a pretty low intensity, but publicly and freely available toolkit It is available on the ONC website. Can help safety net practices and other practices to increase their use of CDS tools, whether or not and how long it may take to get to improvements of clinical outcomes has yet to be determined. Some things that should be examined are use of a simpler version of the toolkit. One could argue for or against using more experienced implementation teams. We really felt it was important to not require prior quality improvement experience, as we thought that would make the results more generalizable. And given the feedback from the teams about the limitations of their existing clinical decision support tools, it seems that having more population health management tools available out of the box for care practices is important, and just highlights the need for continued work to try to see how we can really get to some better integration between clinical decision support and clinical workflows. As far as implications for dissemination, the sites participating in this study all were on the GE Centricity electronic health record system, but there's nothing about the CDS5 rights toolkit that is particular to any particular electronic health record platform. The sites in this study differed a lot in terms of their populations and health center structure, so it seems that it could be applicable to a diverse set of practices. However, it was quite difficult, even with funding support, for the teams to find the time, even for the 2 hours a month, to work on the CDS5 rights on this project, either with or without a practice coach. So that will remain, I think, a challenge as far as dissemination goes. As far as possible policy implications, so the meaningful use clinical decision support objectives, the drafts of it that I've seen so far have really focused on the CDS technology and capabilities, and we would offer that providing more guidance regarding the care processes may be helpful, incentivizing not just use of the clinical decision support, but use of the processes that are likely to lead to improved clinical outcomes may be helpful, and incentivizing improvement on a small number of conditions first may be better than trying to require use of CDS across multiple conditions at the same time, at least until we can demonstrate some improvements in clinical outcomes. And as well as setting higher standards for kind of out-of-the-box functionality to support population health management. A lot of things that the teams were asking for were things that required programming support from the Alliance to build into the electronic health record, and it seems if some of that was available kind of out of the box, that might help move things along faster. I would like to thank our study team. We had members at Northwestern, we had members at the Alliance, Jerry Osheroff, who was helped to develop the CDS5 rights toolkit, consultant on this study, and we also had statistical support from Dr. Shi at Penn State.
Thank you very much, Muriel. There are a few questions, and before we hear from, I'd like to, maybe you could elaborate on your consideration of any advanced medication management tools, like the Universal Medication Schedule for asthma and cardiovascular disease treatment, and in particular how the inclusion of a medication management component of your tool for your study, what your thought processes were on that, and since you also identified going forward, maybe you have some reflections as well as prospectively what you would recommend.
So regarding the Universal Medication Schedule, it's interesting because many of these sites actually participated in a separate study led by one of my colleagues on widespread implementation and use of the Universal Medication Schedule. So I do believe that that was applied in the default decision support for any medications that were prescribed. I think the next question you mentioned was regarding complex medication management, and these tools did include the typical, alerts about allergies or drug-drug interactions, and that sort of thing. So that was a part of this. I did miss the last question though, which was about prospective thoughts. Could you repeat that, please?
So having had your own project, would you approach the inclusion of a medication management, more explicit medication management part of your CDS tool, or not?
I'm not quite sure what you mean by that. As far as the medication management piece, there was the CDS tools both for asthma and heart disease prevention did include drug ordering order sets with decision support. So for example, if based on the questionnaire, a patient was put in the persistent asthma category, there was a link to the NHLBI guidelines step therapy with order sets that go with what medications are appropriate for each step. So I do think there was a medication management piece component. There was not from the get-go perhaps a care management or population health-based approach to that. It was both. It was mainly sort of visit-oriented, at least at the start. So that was our experience in that area.
Okay, great. Thank you very much, Muriel. And now we will hear from Sarah Scholle and Kimminau and their project.
Good afternoon, everyone. This is Sarah Scholle. And so I will start off this presentation and then turn it over. Kim and I will be doing a tag team here on to describe the work that we've done to understand how care coordination is enabled by health information technology, and what will it take to make the objectives and goals of meaningful use a reality. And so we have no financial disclosures. This work was a partnership of NCQA. We're a not-for-profit headquartered in Washington, D.C., and we recognize patients in our medical homes and do other kinds of work to try to improve quality. Kim is from the American Academy of Family Physicians and their National Research Network, and worked with us to design the project as well as to recruit practices to participate. We also worked with the New York City Department of Health and Mental Hygiene's Primary Care Information Project to get some specific help in testing out our methods and understanding information sharing. So I'll just give a quick overview of our project. So we focused on care coordination objectives for Stage 3 of the Meaningful Use program. And this is building on prior work that our teams have done to try to understand how practices conduct care coordination. And so we wanted to understand what was feasible within the current environment of using health IT, and also to ask clinicians and staff about how the care coordination objectives that were proposed fit within their world, and how important they are, and how they see those as helping them to achieve improved outcomes. We used a mixed methods approach for this study, and we wanted to understand what was possible at the leading edge of practices. So we wanted to find practices that already had health information technology in place, EHRs available to them, and that already had in place some procedures for care coordination, because we're looking at Stage 3 of objectives, and so we wanted to make sure that when we went out and looked at it, we weren't going to get nothing happening. We wanted to make sure that practices were already well on their way to thinking about how to coordinate care and how to use their EHRs. And so for that reason, we looked for ways to identify practices that were already Stage 1 meaningful users, so they had attested to Stage 1 meaningful use, and that had implemented care coordination. And for that, as a marker, we selected practices that had received a recognition as a patient-centered medical home. And we did two kinds of research. First, to get a national glimpse at the capabilities for care coordination and the importance that clinicians assign to care coordination activities, we conducted a survey of patients in our medical home practices that we identified from NCQA's list of recognized practices. We also conducted interviews and observations through site visits at selected practices, and that's where we worked with the Mosaic practice-based research networks to identify practices that would represent a variety of practice types, a variety of geographic areas, using different kinds of electronic health records. So we wanted to understand both from a national perspective what was happening through our national survey, and then also to get some more detail about what it looks like in a diverse setting. So what are the objectives that we looked at? So some of the objectives in the Meaningful Use program are actually defined as care coordination objectives. We actually expanded that group a little bit because we thought it was important to look both at the specific objectives that are related to sharing information across settings of care, but also looking at how practices use information to coordinate care for patients over time and within their setting. So that's why the objectives that we looked at included an objective about sharing information from a clinical summary with the patient. We looked at several objectives that related to the referral transition, so using a computerized provider order entry for referrals, providing information along with that referral request, acknowledging receipt of referral. Importantly, we looked at electronic notification of healthcare events, in particular emergency department visits and hospital visits. So this objective is looking to see, does the practice get notified electronically when one of its patients is seen in an emergency department or hospitalized or discharged, or if there's a death. And finally, we looked at the idea of patient-oriented dashboards and how practices use information for population health management. So for each of these objectives, we crafted measures, questions that we asked in our survey. I wanted to tell you a little bit about who the respondents are, both for the survey and in our case study practices. As I mentioned, we were very interested in looking at how care coordination works and how health IT supports care coordination in different types of practices, because they have different patients, and they have different arrangements in their community. So we, for our survey, we actually stratified our sampling frame by type of practice, which included community health centers or federally qualified health centers, practices that were affiliated or owned by a hospital or health system. We also looked at physician-owned practices, and we stratified that group so that we looked at small practices with fewer than 5 full-time equivalent clinicians, and then larger physician-owned practices. So this gave us an idea of how these activities vary across these different practices. You can see in our selection of case study practices, we also strive to look at diverse practices. The practices that are represented in our study used a whole variety of EHR systems. And again, that was something we were interested in seeing because we wanted to understand whether how generalizable these care coordination activities are across different kinds of systems. And we did see, while eClinicalWorks accounted for the majority or the largest proportion, we had a lot of diversity in the different systems. And they also ranged very across, we had 41 states represented in the survey. 8 states were represented in our case study sites, and a whole variety of geographic regions. So we asked the practices to report on the extent to which they perform specific care coordination activities modeled on the objectives that we targeted. We then asked them to tell us about how they use Health IT to perform those activities, and then we asked them about how important these were to getting good outcomes for their patients. So we'll talk about these different objectives and activities in the next couple of slides. So first, we saw a lot of variation in how practices and what practices do in the care coordination activity. And you can see that some activities on that we looked at are widely performed. So providing clinical summaries to their patients. So this was on average 80% of the practices in our survey said they perform this activity routinely. Now remember, all of these are practices that said that they attested to stage 1 of meaningful use, and this was one of those objectives. Over 90% say they send referral requests. Yes, that makes sense. You can see that there are some activities that are less commonly performed. So tracking non-urgent referrals. So practices distinguish between what's urgent and non-urgent in their referral tracking systems, and even this this high rate of referral tracking is related to our selection of practices that have patient-centered medical home recognition, where this is an item that is scored in that recognition program. Often they use reminders. Now, you can see this identifying hospitalizations and ED visits. These are some activities that are less often performed routinely by practices compared to some of the referral transition care coordination activities. Now, this slide, it just builds on the previous slide, so we've still got this 81% of practices performing routinely providing clinical summaries. What we've added with this gold bar is the percent who say they use their electronic system routinely to achieve this care coordination activity. And so for some activities, practices are really doing that activity using their an electronic system. That's what we see with clinical summaries. So they're using the electronic health record to print out the clinical summary, which is the meaningful use objective in stage 1. We see, if we look at things like send referral request, there's a mismatch here, with fewer practices using their EHR system or electronic systems to send referral requests. They may be faxing those requests or mailing them or handing them to the patient. We see that particularly here on responding to requests for information. So you can see the mismatch here. I think of particular interest are these notification objectives that relate to identifying hospitalizations or identifying ED visits. And here we see a full 20 to 30 points difference between what practices are doing and how and whether they're able to use their electronic system to support that work. So identifying hospitalizations that may not come electronically as the objective is imagining, but rather it may come by someone actually looking up on a system or a fax that comes in from a local hospital. And most of the practices had some remote access to records, but remote access doesn't equate to electronic exchange of information. So that issue of interoperability and being able to accept information from other settings was a huge issue. for practices in the survey, and Kim will elaborate more when she talks about the case studies. Certainly we found that when we asked practices about their ability to use electronic systems for identifying hospitalizations or ED visits, they were more likely to be able to do it for hospitals or to which they were affiliated. So if they were an owned practice as part of a health system, they might be able to do it through their the hospital that they're affiliated with, but they couldn't do it with other hospitals in the community. And likewise with the referral, sharing of referral information. So we also asked practices about the importance of these objectives for care coordination and the ability of health IT to support those objectives. And this is, again, a point where we see that health IT support doesn't always match what clinicians view to be important aspects of care. So in providing clinical summaries, most of the respondents said, yes, our system supports doing this, and most of them were using their system to provide the clinical summaries. But we saw that fewer of the respondents actually attached a lot of value to providing this clinical summary to patients. So the connection between this activity and patient care and getting better outcomes for patients was not clear to many of the respondents. On the other hand, if we look at the notification items about the hospitalizations and ED visits and deaths, what we saw here is that these were very important to the practices that we surveyed, but often the EHR system or the information technology did not support those activities. So I think we thought this was important to understand where what's important in the care coordination area to clinicians may not be the things that we can do most easily with health IT, and that making the connection between these care coordination objectives and the potential benefits for patients is something that wasn't always clear to clinicians. We looked at what practice characteristics were associated with care coordination activities and with the use of health IT. And so we created an index for each of these topic areas based on the individual objectives or activities that I've shown you before. And we used regression methods to look at how different practice factors were associated with these indices. What we saw is that practices in rural and urban areas were more likely, did more care coordination activities, and that may have to do with having fewer organizations with which to work. This is consistent with other research that shows better care coordination activities among rural and suburban practices. We found, interestingly, that practices that were very concerned about their finances were less likely to engage in multiple care coordination activities. And we found that this concern, being very concerned about the financial situation of the practices, is really associated with how much practices are moving forward on transformation and adoption of new activities, and that seems to be reflected here. Now, we used Leif Solberg's measure of the capacity of practices to implement change. It's called the change process and change strategy tool. And this is an interesting tool that looks at, to what extent does the practice have structured methods for quality improvement, and are they using rapid cycle change? Do they have practice meetings? And what we found is that practices that are more likely to be implementing those change strategies are also more likely to be doing more care coordination activities and also using Health IT for those activities. An important piece is this idea of having a non-clinician in charge of care coordination. And this gets back to one of the earlier speakers about who's responsible for the different activities that the meaningful use objectives discuss. We found that practices that have a non-clinician who has the role of serving as a care coordinator was related to having greater care coordination activities and being more likely to use the Health IT. And practices that had consultation and support were also more likely to be doing these things. So I'm going to turn it over now to Kim to speak, and I'll keep moving the slides for you, Kim.
Great, thank you. Good afternoon. I'm delighted to tag team with Sarah to share with you the findings from our qualitative work that really was designed to complement or challenge our survey findings and give us a richer picture of issues around care coordination. So let me just clarify and give you a bit of background on what we did to accomplish our casework. These were all on-site visits to sites that were recruited through the American Academy of Family Physicians National Research Network and our P30 grant called Mosaic and our affiliates there. So I thank them all for collaborating. That group includes 13 practice-based research networks from across the country, and they all served as connectors to help us recruit practices for site visits in this case study. So in total, there were 9 of our Mosaic P30 sites from the following states. Let me just rattle them off for you. They include Colorado, Oklahoma, Kansas, Connecticut, North Carolina, Vermont, New Hampshire, and New York. There were a total of 13 sites that we used for our casework. And each of them, as Sarah mentioned, were selected because they represented an independent solo practice, for example, or a large ACO practice, or a hospital-owned practice. So each one gave us a rich display across all of the practice settings that we expect to see for care coordination in primary care. We spent about 5 to 8 hours on site during routine clinic operations to collect data. We had a team of 2 go to our sites where we used a structured interview set of questions to collect data on each of the 6 proposed meaningful use objectives. And we really mixed our methods by asking to observe workflow and also asking to see the demonstration of technical capabilities so that we could assess the extent to which the goals were being met. So, for example, we asked practices to actually see how they could generate a list of patients using their Health IT capabilities for a health condition, their choice. We did it on the fly, but we said that we could use anything that they might have in record for the quality improvement work. So we were very flexible, but we said, let's see if you can generate a list of patients for something like your diabetes patients. And then we actually observed how they did that using their health information technology and their EHR. What that did was that it, beyond just showing us their registry capability, for example, it also allowed us to ask a set of follow-up and probing questions about how they were using that list, or if they could envision using it for population health management. Both observing their abilities and asking them these deeper questions about their interest and levels of importance in using such things like our registry led us to a process where we could score the extent to which the goal was achieved, because they actually produced the registry, And then beyond that, how it was being integrated into the care. So we spent a lot of time watching and learning, not interfering with clinic visits, but catching all of the providers when we could, and we collected that data in, as I said, a structured interview format. And then immediately after our case visits, we compared notes and identified any areas that we thought were important to describe. You can go to the next slide, Jeff. Thank you. So you'll notice that on the left column, we've listed the 6 proposed meaningful use objectives. And what I'd like to do is just pause for a minute to review this table, but bring your attention largely to the last column to the right, which is the extent to which the overall goal was achieved in our assessment. Whether workflows existed or the technical capability was demonstrated, we see a wide variability in levels of actual performance in each of the 6 areas of care coordination that we focused on. And I will point out that if you crosswalk these findings to the ones Sarah just shared in terms of the survey data, there's a good correlation between our observations and that and the data that the respondents gave us in the survey. It's clear that these sort of cross-validate one another, and they gave us a very detailed perspective on each of these elements so that we can make these assessments. Let's go to the next one, where I'd like to summarize the themes that we derived from our work. Just to give you a bit of background, we used immersion and crystallization to identify themes, and we iterated back to all of our notes to identify these 7 core topics that I'd like to share. The first one is variations in the perceived importance of objectives really reflects the same findings we identified in the survey. Clinicians have a wide variety of opinions about how important these objectives are. There is no unanimity virtually on any of them, so that again reflects back to the surveys, and we found a lot of rich detail in discussing these issues with clinicians on site about what they felt on each one of the objectives. There was high variation in workflow and workflow patterns and how they were actually using their EHR and other health IT capabilities to achieve and move towards comprehensive care coordination. The variation we note in both workflow and in the use of their health IT included variability in staffing, who was doing what with respect to coordination, workflow that may or may not have been explicitly detailed as part of quality steps for care coordination activities. There were some technical challenges as well in not quite knowing how to maneuver through the EHR. For example, I'll go back to use the same example of the registry, not knowing quite how to build it, but knowing that their EHR had the capability, but not having the training or technical ability to do so. And then the context, again, the type of practice that we visited had an impact also on how well these workflows were identified and how much support there was to the clinicians and the clinic to use their health IT capabilities fully. We had lots of energy around something like notification of significant healthcare events. When we talked about that, we had lots of clinicians say how frustrated they were that they didn't have a better system using their EHR and health IT capabilities to review things. So an example, again, from our study is that many had to review obituaries in the local paper to look at deaths among their patients. Fax and telephone dependency remains incredibly high, and we posit that the reason these particular strategies continue to remain high is because of the prior conversations about workforce, about workflow, and about technical ability. Precisely because care coordination is of such concern and so important to the care of patients, many clinics rest on their comfort of using fax and telephone to coordinate care for their patients rather than risk losing information, not making a handoff, or having a critical event occur without them being able to put their hands on that information. So it's not that these practices we found during our case study analysis that they're reluctant to use Health IT. It's really the contrary. They're very enthusiastic, but they worry, and that worry leads them to lean on systems that are tried and true. The fourth point about proactive population health management was something that we identified in both the survey and we identified in our case studies, that this is really seen almost as a stretch beyond the capabilities of care coordination that the practices shared with us. Even when patient registries were frequently used to identify patients who need to come in for care, they did not explicitly use that very same process or the same capability to expand their focus into population health management. Number 5, the next theme is that even with their EHR capabilities, Sarah, if you can advance the slides. Even with EHR capabilities and electronic information exchange, care coordination requires really significant and dedicated staff and resources. We saw this, we heard this very clearly from our site visits. This takes a lot of human touch. It takes a lot of acumen, and it just requires a lot of time and resource. And those issues, while important in terms of efficiencies, if EHRs and HIT could streamline processes, as I said from my prior point, they're not quite ready to abandon the tried and true. The buy-in to meaningful use care coordination, and we think is quite context specific. So in the context of the type of practice, in some cases meaningful use moves quite smoothly and is seen as part of routine care without too many bumps. In other sites, it is quite a challenge and very complex, particularly for standalone or small practices that have to coordinate across multiple hospital systems and work with multiple specialty referrals within their community. And finally, the motivation or solutions to address fragmentation seem very local here. We found a couple of interesting local solutions. For example, in one setting, in a hospital-dominated environment, we saw that the hospital actually sent a care manager to the practice to assist in these issues. And in another, we found that the community buy-in to work with their health information exchange really held them together to address a collaborative approach to care coordination. So, we say politics is all local. We think care coordination, to the extent that there are solutions to some of this fragmentation, is also quite local. So thanks. I'll pass it back over to Sarah for the rest of the slides.
Hi, thanks, Kim. So we also talked with EHR systems about our results and asked them what would it take for them to help work through some of the barriers that we heard from practices. And the vendors told us that what they needed is more understanding of the user perspective. They needed a better entry into the clinical processes that would allow them to understand what's needed. They don't want prescriptive rules, but they did think that standards that are currently exist aren't mature enough to really support the interoperability. So, for example, standard formats for referrals aren't ready yet for the kind of data sharing that needs to happen. So just to get to our recommendations, because I know we're running over time here, what we think, based on the findings that were very consistent between the surveys and the case studies, is that one thing that is missing are standardized models for the care coordination workflow. What we heard from practices is that it is about workflow, about having staff that are following the workflow, and understanding how that workflow actually connects to the clinical outcomes for patients. And some steps in the workflow may be explicitly involving patients. So with those standardized models, we think it would be possible to enhance interoperability standards for systems. We heard in both our case studies and in the surveys these challenges of being able to share information electronically in machine-readable forms that get to structured fields that you can then plop into your population management system. Those things don't happen, and that's a challenge. We believe that there should be flexibility to use non-EHR systems to meet the meaningful use programs. Where we saw some of these activities happening for care coordination, it wasn't in the EHR. It was in a tool outside of the EHR that's pulling in information from different sources, and that should be that should really count to the program. But it's not just about the technology. It's about the workflow, and the workflow requires new investments, new resources, and so the payment models really need to support the data sharing, and they need to support practices in staffing to manage care coordination. That's something that's not paid for in a fee-for-service system, and so the payment models, the incentive program isn't enough to support that. It needs to come from alternative payment arrangements and encouragement for organizations like hospitals and specialty practices to share information with primary care providers because that data sharing costs money. And finally, practices need technical support. So I'm going to stop there. Thank you.
Well, thank you very much, Dr. Scholle and Kimminau. You've given a thorough presentation of your project, so we don't have time for questions. When I did read over the summative information by these grantees and also Dr. Ornstein's reports, that when I think about it, if you think of the term humanity, which includes H at the beginning, health, and IT in the end, they all seem to recognize that the integration of HIT within a broader spectrum of the human care and condition and workflow and working teams to be integral. So I want to acknowledge that we've had several very detailed questions that we don't have time to respond to. I will ask the presenters. We will send them to the specific presenters and collect the responses and share it with all of our attendees as well as the PowerPoint presentation. But being an institution of research, we too have evaluations that we have to do. So if you wouldn't mind taking a few moments as I launch the poll so you can identify the value of this particular mode of communication, it would be helpful. So our first question is the AHRQ PBRN Resource Center webinar. You know, how important or unique is this in the conduct of your research or sharing of information? And while you're answering that, I'll also let you know that as these the Meaningful Use SCN grantees publish, we will be announcing those publications through the PBRN listserv, and so we'll be keeping up with you all. And in a few weeks, this webinar will be available on the PBRN YouTube, and we will share that connectivity with you. Okay, so we'll move on to the second quick poll, whether or not you learn from the AHRQ PBRN Resource Center. And now, if this is your first time visiting with us, you can either not participate or, I guess, anticipate how what you've heard today would be applicable to what you're doing. One thing, just to give the discussants a little bit of preview, there were some questions with respect to the validity and how one gathered the quality measures and whether or not the portal information was enhancing or augmenting the quality measures from Dr. Fiks' project. Also, there were discussions about the respect of or questions of how the team is incentivized and or particularly nurses, rewarded in Dr. Muriel Jean-Jacques' CDS discussion, which was somewhat discussed in their application with Dr. Scholle and Dr. Kimminau about the engagement of the team-based care. So with that, in an expedited fashion, I thank you all, and we had a very strong participation, about 400 folks, so that's very good for our venue, and thank you all, and we look forward to sharing these findings as they are published. Thank you. Bye-bye.